Well, good morning, everyone. It's a real privilege to be here today, and what a group to follow this morning. I think the voice of a single patient obviously carries far and wide with all of us, and the emotion that makes us feel. We are blessed to also have a patient on our panel, and unfortunately his video didn't work, and so we're going to have to be able to hear his story in person. So when Kerry joins us, we'll be able to share that thought. But I actually wanted to share a story from my perspective about how I got so passionate, not only about patient safety, but passionate about handoffs. And I'm sure many of you, as you were looking at the stories that were played out in the lobby, saw the story of Josie King. And I know I have friends and colleagues here who were an intimate part of that story. And you know, it was way back in 2004 when IHI had Sorrel up on stage at one of their events. And Sorrel, who we have all heard tell her story, said, you know, gosh, maybe if there had been a rapid response team that I could have called, Josie might be alive today. And I was sitting in the audience, just one of, at that point in time, 5,000 people or more. Some of us have been to those IHI meetings, and we know how large they are. And I don't know whether it was because my son was born the month that Josie died or what, but I just had this connection. And I thought to myself, no kidding, there's a no-brainer. Why don't we let families and patients call rapid response teams? And I can remember going home and telling my organization, we're going to do this. And they all thought I'd lost my mind. And they knew me well enough to know that it was possible, that was not just me being silly. So we started the journey. And like the generosity of patients like Alicia and our colleagues, Kerry, we just cold called Sorrel King and said, hey, I was just one of those folks in the audience. And your story touched my heart like you have so many. Would you come to Pittsburgh? Now, that's not a real easy sell unless you happen to be a football fan. So, and she doesn't like to fly either. But I convinced her to come. And she came and she walked the halls of our organizations. And she inspired us, just like we were inspired this morning and yesterday and the day before. And 3 months later, we rolled out at our first hospital Condition H, Condition Help, which was nothing more than allowing patients and families to call for rapid response teams. 2,000 Condition H's later, across 22 hospitals since 2005, we are very proud of the initial inspiration that was provided. As you've heard Sorrel's story, you know that there was communication issues between the caregivers in Josie's team. Well-intended, super smart, really capable individuals who just didn't get the right messages. And that's what we're here to talk about on this panel. How does that happen? What is missing in the work that we're doing? Because it's not if we don't spend time on it sometimes. We're not always spending the right time. So I'm privileged to have a panel of folks with me to work and share on this particular issue. Now, we all know this issue. I have not spent a lot of time on the root cause of the size of the problem relative to handoffs. You've seen this. 80% of serious medical errors involve miscommunication between caregivers during transfer and handoff. 80%. That means we only get it right 20% of the time? Wow. Breakdown in communication was the leading root cause of sentinel events. Mark's here. He has shared some of their work between 1995 and 2006. And while some hospitals have incorporated customized standards or mnemonics or tools, there really is no universally adopted standard for communication. And in fact, some people feel hopeless about it. Oh yeah, here we are, back at communication. Not sexy, not pretty. What do we really do about it? And the answer is really in the details, as we know. I use this phrase, this is one of those problems that gets very local very fast. And when you think about RPI and some of the methodologies that Mark shared with us early this morning, it is in the diagnostic and understanding your own local issues that progress is made. You know, qualitative studies and surveys among doctors and nurses, really show widespread dissatisfaction over the current handover processes. They're described as informal and unstructured and inconsistent and incomplete. This is data from our AHRQ. We've all seen this. This is information from the 2012 database of hospitals. And look at the number of times the people we even asked today. So this started in 1995. Remember, Mark's data started in 95. I met Sorrel in 2004. It's 2014. Handoff and transitions, only 45% of the time do people think we do an okay job. Things falling between the cracks, important patient care information, problems occur at the change of shift, and shift changes are problematic. Not one of them really is anything to be proud of. And so I think we've recognized that while we've been doing a lot, we maybe haven't been doing the right things. We haven't got to the root cause of what those handoffs and what that handoff communication needs to look like. So with that, I have a great panel that I'd like to be able to introduce you all to. They're each passionate, as I've had the privilege of getting to know them in preparation for this summit. So I have a family practice physician who's from Bartlett Regional Hospital, Southeast Medical Clinic, all the way up in Juneau, Alaska, Mimi Benjamin. Dr. Benjamin, would you join us? I have my patient advocate, Mr. Kerry O'Connell. Kerry, would you join us? We're also fortunate to have an individual who is representing the American Association of Respiratory Therapists and also is the president and CEO of his own healthcare productions company, Patrick Dunne. The director of the Lean Six Sigma program at the Armstrong Institute of Patient Safety and Quality at Johns Hopkins, Laura Winner. We're also privileged to have the Senior Vice President and Chief Operating Officer from New York Presbyterian Lower Manhattan Hospital, Michael Fosina. Michael. And last but certainly not least, the President and CEO of Miami Children's Hospital, Dr. Narendra Kini. Thank you. So, everyone have a seat here. Now it's time to pull out the glasses, as we all know, and we age. I was relieved to see the panel moderators before me also had to use glasses. It made me feel better, a little less self-conscious about my declining vision. So, Dr. Kini, you're not only the president of a really impressive organization, but you've become passionate about this work. And so share with the audience what handoff communication has really come to mean to you and what it should mean to the healthcare industry.
Let me put on my CEO hat for about 10 seconds and start off by telling you I'm concerned about the term handoff to begin with. It somehow denotes that there's a change of accountability once that exchange occurs, and maybe during this summit we can think of a better term that makes sure that that person handing off still has some accountability left. I'll take that hat off and put on the systems design perspective. It was used to define an exchange of information between care providers during the process of coordination of care or episodes of coordination. But I think it's a lot bigger than that. Mm-hmm. A handoff is an exchange of information between people that ensures optimal outcomes. And what I mean by that is, if you think about the patient, a discharge is a handoff. If you think about episodes of exchange such as a police team bringing a patient to the ER and turning over information to the registration clerk, that's also a handoff. And in fact, a prescription is a handoff. So the concept of a handoff from a design perspective should be expanded to include any exchange of information that ensures optimal outcomes.
Great. Well, I think your point about not transferring, not being able to wipe your hands of accountability is a critical issue. So, Mimi, you're in Alaska, which you've come to the South now. It's much warmer, but no matter the size of our organizations, we face many of the same issues. And so, what really made you guys realize you were having a problem at Bartlett?
Well, when I came to Bartlett Regional, I came from a big setting. I was working for the University of North Carolina, and I had never worked in a small hospital, and I had no idea about the challenges that they faced, the lack of resources. And so I joined the peer review committee, and they were very excited about their core measures. And looking at their denominators, they had admitted 5 MIs over the whole year. So their core measures I didn't think were really all that meaningful. And as we were reviewing sentinel events that had occurred in the hospital and perceived errors, we noticed that about 50% of the cases that we reviewed in 2010 had to do with communication errors. So we said, okay, the first thing you always want to do in quality improvement is find the problem. And so we found that really if we wanted to make a difference in our hospital, we needed to look more at our problems than at national standards and address those problems.
I think that important of getting to the local quickly is critical. Now, Laura, you're not only an expert in Lean Six Sigma, but you're also a nurse from that kind of background. And so what led you to recognize this was an area similar to Mimi or different?
Yeah, so similar to what Mimi shared, our organization also saw many of the errors that were reported by frontline staff into our event reporting system. As we all know, many errors have many causes. And so a significant amount, as much as 75% of the events that were entered into our reporting system identified handoff communication as an issue in that error. So that really was the catapult for us. And I think additionally, we are very fortunate to work with our physician leader, Peter Pronovost, who's very passionate about patient safety. One of the things in the early 2000s, some of the work that he did was he came to the uncomfortable realization that he works also as an intensivist in the ICU. He came to the uncomfortable realization that we would bring an interdisciplinary team together. We'd have great dialogue about what needed to happen for this patient. We'd agree on goals. But then we'd all walk away and have just a vague idea of the goal without a concrete, specific plan. And so one of the things that he put in place was a daily goals communication sheet. And I think that just raised the awareness of the whole organization about the importance of the handoff. Additionally, the Joint Commission in 2006 introduced this as a national patient safety goal, and that really resonated with us. The other thing being an academic medical center, we also are dealing with the 80-hour work week, which we know has increased the number of handoff communications. And then additionally, we've had the expansion of our electronic medical record, which we know has changed the way we all communicate.
Well, you know, there's a good follow-up question there on that, and that, you know, we've talked a lot about electronic medical records over the last couple days, and heard a little bit of the pros and cons of the impact they've had and the unintended consequences. And so, has the EMR helped you make your handoff better or worse? Is it less complicated, more complicated? And speak freely.
Well, it's a complex issue because there's no question that the electronic medical record brings some patient safety features. You know, there's functionality such as forcing functions so that you don't choose the wrong dose for a pediatric patient of a certain weight. There's also prompts and reminders to help clinicians avoid those slips and lapses when we forget to do evidence-based practice. There's other advantages. We heard about being called in the middle of the night, 3 o'clock in the morning. Electronic medical records are accessible remotely, which is a great advantage. At the same time, just as we all see in society that the smartphones and texting has dramatically changed the way we interact, we're seeing the same thing in healthcare. We're seeing less face-to-face communication. And so I think it's really a two-edged sword.
Well, that's, I think, really insightful. I'm going to go to Kerry, who is, he's been a delight to get to know over the course of the development of this panel. And Kerry, maybe just for a couple minutes, you could just tell us your story of how you became a patient of this at times, as we know, broken healthcare system.
Thank you. You probably get to see the video on the website someday. I did warn him that I'd break the camera.
It was so powerful.
But no, I was just a guy painting my house one afternoon, fell off a ladder, dislocated my elbow, which launched me into the world of orthopedics. And in the process of fixing my elbow, they screwed an external fixator on the outside of my arm and wrapped my radial nerve around the drill bit, which wound up paralyzing the arm. And then we tried to take a nerve out of my leg and splice it in to fix that problem, and that didn't work because the graft was too long. And then we tried to clean the scar tissue out and then got an infection like Alicia, and that launched me into 4 surgeries to kill off the infection, and finally ended up by doing tendon transfer surgery and rearranging all the tendons in my arm to get it working again. And I was fortunate. I spent 2 years in the healthcare system. I saw the best and the worst. I wasn't so sick that I couldn't notice what was going on, and I got to know some really neat people. And I got to make a lot of observations about things, and I was an engineer, so I wrote them down.
Yeah. And we'll come back to that later, the value of that, writing it down. So you've had, talk about handoffs. You probably can't even count the number of handoffs that you've been through.
A lot of the handoffs kind of look like the Fast and the Furious. A lot of them kind of look like Olympic swimming, where the swimmer hits the wall and the next guy takes off. Quite different from what I was used to in construction. We do a lot of shift work. We have handoffs. About 10 years ago, we started making the second shift supervisor come in half hour early. First shift supervisor stays a half hour later, and we'd have an hour of handoff time, and that helped a lot. It really helped a lot, just getting the supervisors. But then we realized we couldn't really we were still having quality problems, still having injuries, so then we came up with the idea of integrated work plans, where we take all this information, plans and specs and tool information and weather information, pull out the really important stuff, put on one big old piece of paper that's like 24 by 36, hang it in the toolbox, and then the whole team would participate at the end of the day in reviewing that plan, and the new team coming in would review it with them, and any changes to the plan were documented in writing with little magic markers on the plan. And once we got into team handoffs, of going team to team instead of supervisor to supervisor, then we actually got our accident rates very, very close to zero, and our quality went up exponentially. It worked really, really well. But the one thing that I noticed about in healthcare, there's probably my greatest revelation in the last few days, was that when I kind of let my first surgeon go and switched to a second surgeon, there was no communication whatsoever. And I can understand that. We take over building projects. We don't call up the previous guys and ask them how they got fired. And I understand that, but then I got to thinking, there's Dan Ford's here. His wife incurred multiple medical errors over the course of treatment. I incurred multiple medical errors over the course of 2 years. Alicia incurred multiple medical errors over the course of 5, 6, 7 years. And I got to thinking, why is that? That'd be kind of like winning the lottery twice, It's statistically highly unlikely. And I think that the post-handoff our post-harm handoffs are probably the weakest and the worst there is, because the rumors start flying, people start getting scared about what they say, start getting scared about what they write down, and the cloud of shame just comes down on the whole organization and things fall apart. And so I think the patient you are most likely to harm is probably the same one you harmed last week, and it's kind of insidious. It's kind of sad. But.
That's amazingly insightful for all of us, because you're right. It's that human response to the error that we all feel, and it's also amazing. I'm sure we'll hear in our panel later this afternoon as we get to Just Culture about what do we do for the survivors of those adverse events, and how do we take care of them. But the one thing that you said that strikes me the most is it really is the team. It was the team, even in the field of construction, different than healthcare, that came together to make things smoother in your business world. And as we all know, those principles are starting to apply in our world now. So Patrick, you're a part of the team. Sometimes in the past, maybe not as a prominent part of the team, but thankfully, we've heard over these last few days how that's transforming. So, as a respiratory therapist and a veteran of the profession, why did you start to look at handoffs? What was really your prompting?
Well, actually, the American Association for Respiratory Care is our professional association for the 150,000 plus respiratory therapists who practice in the United States. I should point out 75% of which practice in hospitals, and we know that's going to change as the site of care is moved to post-acute. And first and foremost, we're a patient advocacy group, so we're very much enamored with and fully embrace patient safety. We have a history of using checklist-type documents or resources with VAP, because the implementation of the IHI bundle was very important. You have to inspect what you expect, and so various departments were using various types of checklists to really improve adherence. About several years ago, we became aware that several sentinel events were filed with the Joint Commission for preventable harm to patients who were being transported within the hospital who required oxygen supplementation or oxygen monitoring. Maybe going from point A, the emergency room, to radiology. Maybe going from radiology to the emergency room. The emergency room, I should say, to the cath lab. And what was happening is that there are two elements. There's going to be the oxygen delivery system, there's also going to be the oxygen monitoring system, and there's going to be the patient. So we convened a panel of experts and decided to create for our members a checklist, a safety checklist that would basically alert people involved with patient transport, in-hospital transport of patients who required oxygen supplementation and oxygen monitoring. And it's divided into three parts. The first part is basically patient demographics, what time we're leaving, what the patient's condition is, patient readiness. In that is also the DDR, the drug, the dose, and the route of administration. What is the oxygen flow rate? What is the route of administration, which is a mask or cannula, and what is the liter flow? So all that information is entered into the patient readiness. We then also decided to make sure that the monitor is ready. So there's a checklist to draw attention to elements in the monitor. Is the battery sufficient for the duration of the transport? Are the cables frayed, or are they connected properly? Is the sensor properly working and applied properly? And then the third is to allow the person providing the transport to actually look at the regulator, measure the pressure, and then plug in the liter flow and really easily determine how many hours are going to be left before the cylinder runs empty. So it's in a way to draw attention to some of the critical factors that could go wrong, again, unintentionally. And I'm learning today that the Joint Commission now is very concerned about the segregation of portable oxygen cylinders to try, again, to further reduce a partially filled cylinder being picked up and then having a catastrophic emergency while waiting for the elevator. So we feel that our members are very, very fortunate to have those resources, and we make them available free of charge to anybody who wants to download them. And we're actually getting a worldwide uptake because we have several international members of the association as well.
That's, that's amazing. I think, too, you bring to bear the importance of the professional associations across the world here in the States and raising awareness and becoming really strong advocates. And so after you did that, I'm sure there was a ton of learning from doing it. And so, when did the light bulb go off after that? What was your biggest learning after beginning that work and starting to spread that message?
It's interesting, it actually happened subsequent to that completion of that project. We developed another checklist for monitoring ventilation. We're monitoring oxygenation. We're also going to be monitoring ventilation. And there was just really no literature. There was a lot of work about apnea monitors, but that's not what we were looking for. We were looking for ways to monitor ventilation. And we were drawn to an article that was published over 20 years ago out of the University of Virginia, where they looked at the readmission back to the intensive care or critical care unit once patients were transferred out onto the floor. And we'd all like to think that patients are transferred to the floor for the right reason. They're clinically stable, we're backing off on the utilization of medications, but sometimes it might be that, who's the least critical ill because we have someone down the OR who's coming up and we need that bed. It turns out that the mortality rate for patients readmitted back to the intensive care unit is like almost 40%. Very, very high. And that's when I think the aha moment went off. So we convened a panel, looked further into that article, and the subset of analysis showed that only 30% of the patients who were readmitted to the intensive care unit actually have a worsening of their original condition, meaning 70% are having another complication, of which 50% were respiratory related.
Wow.
So we decided to develop a risk assessment because since ventilation is part of our domain, to basically identify risk for relapse. And it's again divided into 3 areas. The first is the patient readiness information in terms of what their status is, what their vital signs are currently, what types of respiratory support they're on. The second is to then look at whether or not the risk factors that we identified in the literature are present. And there are 9 of them, and it's a drop-down menu. And we ask, for example, is there a suspicion of obstructive sleep apnea, either confirmed or suspicious or suspected? Has the patient been in the intensive care unit longer than 2 weeks? Is the patient on dialysis? Has the patient received mechanical ventilation? Does the patient have a gag reflex or an intact cough? And then what we basically do is assign a score of anywhere from 0 to 9. Anybody above 5 is potentially a high-risk patient for relapse, less than 2, low risk, but still someone at risk. And then we decided to how will hospitals use this? And we said, we'll leave it up to each hospital to individually decide how they're going to handle that risk assessment. Are they going to have a special department? Are they going to have rooms closer to the nurse's station? And then the real aha moment came with how do we monitor respiration? And the technology, there's 2. There's the end-tidal CO2, which we've heard is somewhat problematic. And there's the new technology, which is acoustic respiratory rate monitoring, which is, of course, because we now realize the first vital sign to go south when something is wrong is the respiratory rate, and it precedes, sometimes by hours, any changes in the arterial saturation or the change in the heart rate or the blood pressure. Sure. So respiratory rate monitoring, I believe, is going to be an important part of our professions promoting patient risk assessment when the patients are removed. And I was really delighted to see the third aha moment came Saturday afternoon when we saw Children's Hospital of Orange County talked about their deterioration continuum for the non-ICU patients. And I looked at that and I says, we're doing the same thing. They're trying to identify the intensity of resources to prevent the deterioration early on rather than wait until it happens. So it seems that we're basically on very, very good ground in that regard.
Well, it also demonstrates the power of shared learning. So, this problem, as we all know, is not new. but yet we still continue to find it pervasive. And so, Laura, when Hopkins began this journey, because you've had a lot of leadership in the world of patient safety, what approaches did you try initially, or what did you use?
So early on, we did what a lot of organizations did, and we adopted crew resource management from aviation. We also embedded in that was the SBAR tool that some of you might be familiar with. It comes from the Navy. It's a tool that's used, it's a mnemonic that stands for situation, background, assessment, and recommendation. And so our early results for that were kind of mixed, because we found that that tool works in specific situations, but not for every situation that we were encountering and the process failures we were seeing in our handoffs. We have been applying Lean Sigma at Johns Hopkins since 2004. And in 2009, we were invited by the Center for Transforming Healthcare to participate with 9 other hospitals that have experience applying the robust improvement tools of Lean Sigma to try to get at the heart of what really leads to these lapses when we are conducting these transitions of care. We were very fortunate and had a very positive experience through that work with the Joint Commission.
Great. Well, Mimi, too, I think your organization actually became a part of some of that work. And did you use similar approaches, or what did you find were some of your local initiatives initially, and how did they change?
Well, initially, we had sort of identified our communications errors mostly between the emergency room doctors and the primary care doctors. And because I came from North Carolina and Duke used it, we did the same thing. We used SBAR. We made little cards, and nobody would do it. People say, yeah, that's great, but people don't even really understand how to fit medical problems into SBAR. So it didn't work, and luckily we did a very fast PDSA and found out quickly that it wasn't going to work. So I actually literally went online because I knew that somebody was working on this and had to be working on it, and I didn't want to reinvent the wheel, and we didn't have a lot of resources, so I Googled patient handoff and found the Joint Commission's project, basically. And these guys over here were doing all the work, really, for us, because we don't have the resources, so we took what they did. And the tool is basically one that you can do without the resources. So the Joint Commission becomes your resource, and they help you. So we formed a team, and that was very important. We needed champions. We needed physician leaders to be champions, and we got 3, which we only have 30 doctors or something, so that was a good percentage of a team. And someone who was skilled in organizing us, the regulation person in the hospital. And we just went ahead and said, okay, let's go ahead and try this tool. And we also then figured that the important thing was, and I was a receiver, I'm a primary care doctor, so I knew some of the problems already, but we went ahead and asked everybody, all the receivers, what they were missing. And that was our initial approach. And then we also took a look at the areas where the handoff was occurring to see if we could find any problems there as well.
Great. So a lot, again, that the shared learning theme just continues across all of this. Now, we were talking a little bit earlier with Patrick about the importance of team, and I'm curious, Narendra, we've heard that every caregiver has a perspective here, but is there really a difference in how the problem is approached depending on what job you're in or what role you have?
I think there is, and we approached this problem during our system design by doing Lean. We built actually a value stream map of the handoff process. Mm-hmm. And I'll share some observations that I think are relevant to be able to answer the question.
Please.
First of all, there's about 5 to 7 handoffs per episode at any point in time per patient. So in a teaching institution like ours, you have the students, you have the medical students, residents, fellows, the attending, the nurse, the student nurse, just to give you a quick idea. We then looked at it and realized that the templates they use to hand off are different. They also occur at different times. So there's a substantial variation in the information that gets passed about the same patient and maybe even the same problem. And the most interesting thing is we're fully electronic, but the entire handoff process is built off of index cards or other paper pieces, which they extract from the EMR and then write it down and then talk. That was a very, very interesting observation. The second part is about 60% or more of the handoff process is actually voice. It's communication. It has nothing to do with the documentation templates that we're talking about, and that is a completely unmapped process. We're talking about the S-bar. In my institution, half of the patients are Latin, and if you listen to what happens during a handoff and compare what is perceived by the patient who is of Latin origin versus not, there's a substantial difference. So the tool of communication, i.e. conversation, is the most unmapped, least researched of the handoff areas, and it's also the weakest in terms of providing for errors. So we've done a couple of things to try and address this. One of them is to integrate the handoff template into the electronic medical record. So there is now a template that contains about 7 pieces of information, and it is also color-coded so that anybody who looks at it and sees red sees that there are 3 things that must be acted upon, and the other is general information. The second is we're trying to get into a single universal handoff template that's adopted by every person, and I use the word person because it's providers and non-providers. And the third is to allow the family to look at that at the same time that the goals are discussed with the family. So visualize the handoff template. Lastly, we started to talk about mapping voice and trying to understand the role of voice in handoffs and what people would say, so that someday we believe there will be an acoustic equivalent of the S-bar. There is no such thing today, and I think that's one of the biggest weaknesses. I'll tell you, we've built the map, but I don't have a great answer at this summit. Hopefully next summit will give you some results on what that is.
Well, we'll hold you to that for sure, for sure. But I think, Mimi, you had some of the same discoveries about style of communication and that impact on when you started to look at some of the causes of the handoff problems between the ED and the attending physician. Tell us a little more about what you found there.
Well, that was something we didn't expect at all. And that was very interesting. So we made this assumption that because the ER doctors are mostly calling the family doctors on the phone, either in the middle of the night or during their office, that was where most of the handoff should be done. And most of us wanted that. But there was another group of doctors who said, I don't want all that. It's 3 in the morning, my wife is sleeping, I want to know a few things. What's the condition of the patient? What's the name of the patient? Do I have to come now? What's going on? And so we actually had to take our tool and divide it in half. The first half being the very critical information that everybody wanted, and then the second half was, do you want the rest now, or are you going to come in? So that was really interesting, and we didn't expect that at all. We also found we had our similar problems with the EHR. The ER doctors have one EHR. The attending doctors in the hospital have a different one. And we can't get information very well across the board, so we found out there was missing information. Finally, there was written information that wasn't in the EHR. There were EKGs that weren't in the EHR. If an outside radiologist read a CT scan, they faxed it and put it on a piece of paper, and it wasn't part of the record. It was sitting on the desk. So sometimes you didn't even know that they had done a CT scan. So we worked really hard. That was our areas of error, and we said we need a chart in the ER that's comprehensive. We need to get our telephone communications more standardized. And we need to know, and both sides really need to know what's available. So the receivers need to know what to ask for. Because there were some great things in the emergency room's electronic health record that we could ask for that we didn't even know existed. So we found all kinds of things.
Well, and the theme of the accessibility of data, Joe, I know you're back there, is part of the theme that we keep finding and needing to have to obviously address. So Narendra, just back to you. You talked about your value stream map and that you did at Miami Children's. Were some of your really, when you got down to the root causes, some of the similar issues that Mimi had, or what did you find as the actual key root causes locally?
Yes, I think a lack of standardization of the data is the #1 issue. People also don't assign acuity to the data that they share. You can get a standardized handoff, but if people don't realize that the top line to go and check that potassium now is emphasized, then you have a handoff without the intended outcome. So there is a lack of, there's variation in the data shared too. There's no way to really pinpoint emphasis on critical data or critical interventions that must be done. The third, which I think, we thought it was something that was unique to us, but I'm now beginning to realize should apply to everyone, is there's a cultural component to all data sharing. And it's really doubled and tripled in a children's hospital, because there's mother, there's grandma in our place, and now add the fact that they may be of a Latin background, and when you start to share information, it's not only perceived, but it's also acted upon differently. So there is a huge cultural component to handoffs that we were not aware in the initial research and value stream mapping, that we're struggling to teach our providers right now how to be culturally appropriate during handoffs to make sure that the outcome is actually ensured. So those were the big areas.
So we've been talking a lot about handoffs within an organization, and we're fortunate to have Michael here, who, as representing the voice of leadership and leadership commitment to this issue, and then in addition to that, some of his initial work at New York Presbyterian went beyond the walls of the hospital. And obviously, Michael had the opportunity to do some work in the area between inpatient and downstream skilled nursing facilities. And so, Michael, do some of these things resonate with you too? And did you see different causes of problems with handoff?
They all resonate. Everything we were talking about here, and my colleagues will talk about it, were the same things were happening in our organization. We put a major emphasis and focus on improving the handoff communications and improving the tools and changing the tools and getting connected with the Joint Commission and their team to start doing that. But at my particular campus, I had a unique situation in where we had a very senior community. And we had a large number of nursing homes in the community, a large number of elderly. And we were getting patients from the nursing homes going to the nursing homes, and I was watching the numbers go back and forth, the number of patients that were admitted and readmitted from the hospital to the nursing homes. It became real clear really quickly that there was a problem here that we had to solve. So I went out and met with each of the CEOs of each of the nursing homes. Went, introduced myself, talked to them about some of the things that I'm seeing, talked to them about our need to gather together and talk about this issue, to improve the health status in the community, to ensure the safety and the continuity and quality care for the patients in our community. And we had to be open and honest with each other. And if they had a problem with the hospital, they needed to come tell me. I needed to know about it. And it wasn't about getting somebody in trouble. It was about, I got a problem I got to solve. But they had to be open to the same thing. They had to be open to, if we're finding something, there's some communication is that we had to work on. And we got agreement from everybody to do that. And we started, talking about what are some of the issues. So, the discharge planner is talking to the admit coordinator in the nursing home. By the time the patient gets discharged, it might be hours later. The doctor may not be at the nursing home at that time in the afternoon. They might have changed shifts with the nursing staff are there. The patient would go over. They weren't sure what exactly the patient was coming for, what all of the underlying conditions are, and they would send the patient back to the hospital to the emergency room, and the emergency room doctor is calling back upstairs and saying, did you guys just discharge this patient? Why are they back here? And this would go on, back and forth. And after several months, we got all of the CEOs, medical directors, nursing directors, and MIT coordinators together. We said, all right, let's talk about this. This is a common problem. And we needed to standardize the tool. First, we needed to find out what information do they need to have to accept a patient. And then we wanted to know when they're sending a patient. Just don't put them in an ambulance and send them over to the ER and for our docs to figure it out. This is causing a significant amount of backlog in the emergency room, with unnecessary hospitalizations. And so by working together with all the different nursing homes in the community, we started talking about how to standardize a tool, What do they want? What do we want? And as we started to work through that, we started to see more and more continuity and quality of care for the patient. So if you think about the complexities that you have just trying to do this within your organization, now you're taking a completely separate facility several miles down the road who the providers may or may not know each other. And that just adds another level of complications to it. And we started meeting together and putting faces with names and started to improve the communication, the verbal communication, the written communication, the electronic communication, to really start seeing what was happening and start to improve this transfer.
Well, I think one of the points that you make, Michael, too, is so critical is that, you know, healthcare is still about people and relationships and the connections that need to be formed. And for you as a senior leader, and I'm sure Narendra does many of the same things, to go to that effort to meet your peers and to have those conversations, I think goes a long way to the formation of community in solving problems. And you know, look at where Mimi is. I mean, she is the community. I mean, there's really just a very small healthcare support structure in our town. Although she was telling me your volume goes up by like 5 times in the summertime and it shrinks down to nothing in the winter. I don't know why. I haven't figured that out yet. But you know, nothing like having to have variable staffing, which means you have to have flexible solutions for that. But so, you know, you've heard about some of the different solutions folks have tried. As you kept going down your root cause, what were some of the things that you tried, Mimi, to get this handoff between your physicians strengthened, different?
I think number one was just education. Mm-hmm. Because truly, senders and receivers, the senders don't always know what they're not communicating. And interestingly, part of the Joint Commission project is to query both the senders and the receivers, and the senders usually say, nothing's wrong, right? I did a great job. But interestingly, if you ask them, well, what happens when you're a receiver and someone's sending you someone for the office? How does that go? And they say, well, it goes okay if I get what I want. So the first thing was to educate them, and that's what we used the tool for. We took the tool, as I said, we made it in 2 parts and said, please include this every time. The second thing was to really encourage them to think about what we might be missing. What do I want to communicate? Don't I want this EKG that's sitting on my desk to be part of the clipboard? And then to educate the receivers. We educated the receivers. We said, if you don't see, there's a very nice piece of data that comes out of their computer that shows everything the patient's been given, the timing, everything. And we didn't even know it was there. So now we know to ask, where's that nice thing that you usually put on there? And where's the nurse's note? And where's the doctor's note? So we built the chart better. Mm-hmm. And then so finally we just started to get everybody used to doing the tool. And now the tool is not there anymore. People don't need the written tool anymore because they're so used to giving that.
Become a part of your culture.
It's become part of our culture. And the interesting thing that we did find in terms of outcome, we said, how in the world are we going to measure whether we're doing a good job or not? Because clearly we used the query tool and the receivers all felt that they were getting a better handoff. So that's one thing. Okay, so we reduced it, interestingly, by 56%. The same as the national numbers with such small denominators, but 56% of the time people felt they were getting a better handoff. But then we looked at every time we reviewed a sentinel event or a perceived error, the director of quality assigned a reason. And in 2012, so we were at about 40-50%. In 2012, there was only 1 case that was involved. And in 2013, 0. So no cases do we think of errors actually were from the handoff.
Wow.
So that's where we ended up.
Really super, super impressive, tremendous work. So Kerry, you've been quietly listening and taking all this in over the last couple days. And so I want to put you on the spot and ask you to say, you know, what are the, you know, couple things that you would tell all of us as healthcare professionals that make a handoff good? What are those things?
Well, I think a lot of people have talked about medical language, and I was right after surgery number 6 or so, and they came in one morning, said, we're going to put a Groshon catheter in you. Great, whatever that is. And then they came back a few minutes later and said, no, we can't do it. The hospital's out of them. We'll bring one up from Denver tomorrow. So I stayed up all night, and I studied Groshon's website and found the surgical technique manual and pretty much memorized it. And the general surgeon came in the next morning. He says, Mr. O'Connell, you know what a Groshon catheter is? I says, yes, I do, and here's the 10 most common complications, and you need to go through them with me and tell me how you're going to avoid them. But I don't know how many people are that anal, So, I mean, you could really easily walk into the patient's room with a sample of a Groshon catheter that you don't use anywhere and say, this is what they look like, guys, and here's a technique manual if you want to see how it goes into your heart, and answer a lot of questions a whole lot easier than what I did. And so language is really important. I found doctors, with all due respect, to be some of the worst listeners I've ever met in my life. About 8 seconds in, they would start interrupting me all the time. And so I truly believe that the best handoff is from a doctor to another doctor with a nurse present listening and a patient present listening. So you got 3 people to verify what was said and what the plan is. I think you got 3 times more likely success if you have a joint handoff instead of a person-to-person handoff.
Agree.
And it's pretty simple. You didn't have to do a lot of studies to do something like that. But
Yeah, well, your comments are just priceless, and I think they get right to the heart of the matter, and as complex as it is, I think the challenge for all of us is to make it simple. And this is one of those topics where, as we've heard through all of our panels the last few days, you could go on forever. And so I'm going to take a little bit of liberty in moving us along here. And just wanted to just hear a couple quick hits on outcomes. So, Laura, you've put some solutions in. What kind of outcomes have you seen?
Yeah, so as we worked with the other 9 hospitals with the Center for Transforming Healthcare, one of the things that, and Mimi mentioned this as well, that we recognized early was the mismatch between the sender and the receiver. So some of the interventions that we put in place was really sitting down and understanding what data was needed. One of our aha moments, though, was that one of the senders, when we talked about a critical data element, explained that they weren't giving that information during the handoff because it's in the record. And so that was a real eye-opener because when we walked the process, we learned that the folks at home care didn't have access to that electronic record where they were supposed to find this information.
Oops.
So we were fortunate that we found a simple solution to that particular part of the handoff process. So once we had everybody up using the same electronic medical record, we actually were able to then leverage that technology a little better, create a format where we had agreed upon data elements that were exchanged. Everybody had access to that IT system. We saw a dramatic decrease in defective handoffs, dropped from 43% down to 5%.
Wow, that's an impressive. What about you, Michael? I know in your work between the nursing homes and the hospital, what did you see as an effect of this?
We saw a reduction in readmissions by about 50%. And that was pretty dramatic. And the team at the Joint Commission and the tools that they have were extremely helpful. We continue to communicate with each of the skilled nursing facilities. We can identify who's sending us what type of patients. And then we've gone over to talk to them about, looks like you have an issue here. Did you know it? That's question number 1. And if they did they need help with it? And how together as 2 partners can we work together to improve the overall health status of the community? We saw the reduction in the readmissions, but what else did that do? That improved throughput throughout the hospital. We didn't have patients backing up in the emergency room, waiting for beds upstairs. We were able to more timely send people out of the hospital to the nursing home, so the provider in the nursing home that accepted the patient will be there when the patient arrives. Right? So we saw a throughput through the hospital. We saw a reduction in our length of stay, a reduction in our readmissions, And ultimately, that has a reduction in your costs.
Yeah.
And that's ultimately what we're trying to do, reduce costs and improve quality and continuity of care. So it's been a very dramatic process, and one that we're pleased to be on this journey with.
Well, these are all impressive findings, and I think we'll wrap up. I'm going to put Narendra on the spot a little bit here. We just wanted to hear a little bit about vision. So what in your mind does the ideal handoff communication look like in healthcare 5 years from now? What do you think that will be?
I think we will see a culturally appropriate tool that's embedded not in the electronic medical record, but as an app. I think it will become totally ubiquitous. It'll be in the smartphone, it'll be on the iPad. It will contain all of the elements, and any critical data that's in that tool will trigger an intervention. So that kind of integration will be the first evolution of a smart handoff app. And I can already tell you we're hard at work developing it. That's why I'm so confident that something like that will come through. The second component of it is I think there will be significant use of telemedicine. There are now telemedicine apps, and if you think about handoffs and the fact that multiple providers are not at the same place at the same time, if you were to deploy a telemedicine app, you can get an attending, a nurse, and anybody else at the same location, even if they're not there physically. And a couple of those technologies coming together with an appropriate set of data that is important for outcomes, I think is somewhere in that region will evolve in the next couple of years.
Well, that's certainly a great vision, and one that, again, we'll hold you to. So I thank you all for your wonderful comments. I know we could go on forever, but that's the end of our time, and we thank you all for your attention.
Thank you.